Our next speaker is Jonathan Rubenstein, and his talk is titled My Indications for PCRIs.
Thanks, Kevin, and thanks for the invitation to give this talk. We're going to talk about peripheral corneal relaxing incisions, which were kind of the mainstay of astigmatism treatment for a long time, and really before toric IOLs came along. So why do we still need to know about this? It's my disclosures, which is not significant to this talk. Why do we still do peripheral corneal relaxing incisions? Well, first of all, they're low tech, and you don't have to go out and buy fancy equipment. All you really need is a quality diamond knife, and these can range from $400 to $2,000 or so, and some sort of toric marker. It's cheaper for the patient. It's cheaper in the whole healthcare sphere, really. There's no premium IOL fees. There's no femtosecond laser fees that the patient has to pay. It's pretty much very accessible. All you need are those two instruments, diamond knife and toric marker. And it's got multiple other uses, and it can be an adjunct to some of these other technologies. So it can certainly be an adjunct to toric IOLs. So if you've got a toric IOL and you want to correct more than 5 diopters, you can add it to the toric IOL. If you do a toric IOL and you're sort of between powers, you can do a little peripheral corneal incision to add to that. So we'll talk about some of those details. What are peripheral corneal relaxing incisions? Well, really, this is the anatomically correct name for what's always been called limbal relaxing incisions, but these incisions aren't made at the limbus. They're really made in the most clear peripheral cornea, so peripheral corneal relaxing incision is the correct term. 90% depth incisions made in the steep meridian, most peripheral clear cornea, and usually with a diamond blade, and you can either have a preset blade set 600 microns or a blade that is adjusted based on peripheral pachymetry, if you can get that pachymetry. The important thing here is what's here on the bottom, that the effect depends on the technique you use. And this is where these incisions, I think, get a bad rap, because very often correct surgical technique is not being used, and we'll talk about that also in a moment. We're going to have a talk on femtocorneal incisions next after this, but just to compare the two, this is a peripheral incision very similar to the manual incision, but it's made with a femtosecond laser. So therefore, it's basically independent of surgical technique. You get these beautiful incisions. They're programmed through the laser, usually 80-90% depth at a 9mm optical zone. And surgical technique really doesn't enter into the equation here. So how do we do it correctly? Well, alignment is critical. So garbage in, garbage out. If we don't have these astigmatism, if we don't have the correct calculations ahead of time, it's been talked about in assessment of astigmatism, and if we don't have the correct alignment, then we're not going to get the correct effect. So what I like to do is a simple mark on an anesthetized eye right at 6 o'clock. I have the patient sit up, look at me with both eyes open, either looking at my nose or a distance target, and I sneak up and make a simple mark at 6 o'clock. You can also mark 3 and 9 o'clock, but I found sometimes the markers cause the patient to recoil, and you get a little bit of a torsional movement of the eye. Then in the operating room, you need some sort of astigmatic dial or marker that aligns that 6 o'clock mark with a 90-degree mark on the astigmatic dial and marks your steep axis of astigmatism. You either measure the thinnest peripheral corneal thickness or, again, use a preset diamond knife, and most of the preset knives are at 600 microns, and make these incisions before your cataract surgery. And it's important to use a single foot plate blade so that you can see the blade towards you with a foot plate away from you, so you can see if there's any irregularity in your incisions or any micro perforations. And it should be a double cutting blade, because you want to be able to you want to be able to move the blade depending on the anatomy of the eye. So certain people have different shaped orbits, nose, brows, and so forth, and sometimes it's easier in that patient to push a blade, sometimes easier to pull a blade. You need to know a good nomogram and develop and trust a nomogram, and most of these incisions can correct up to about 3 diopters if you push it of astigmatism. And the techniques, again, are dependent on nomograms. There are multiple nomograms out there. This happens to be Doug Koch's nomogram. Skip Nickerman has an excellent nomogram as well. Some of the earlier nomograms by Jim Gills are out there as well. But develop some sort of use of a nomogram and then modify your results based on your own data that you should collect based on that nomogram. You have online nomograms available. For example, that was the AMO nomogram is still present with Johnson & Johnson, LRIcalculator.com, and allows you to use either the Nickerman nomogram or the Donenfeld nomogram. And again, you make these incisions, or I make these incisions at least at the beginning of the case. The cornea is still pristine, so the epithelium is smooth and regular, the intraocular pressure is controlled, and I make it as my first step before I make the paracentesis in the eye. This is where I've talked about technique is very, very important. You've got to remember that the cornea is a dome, and it's a dome for 360 degrees. It's not a flat surface. And you have to maintain perpendicularity to the dome with your blade. So if you come, like you see on the example to the left with a vertical blade, you're not going to get the penetration in the depth that you're expecting. You really should do what the blue arrow is showing you and have the blade that's exactly perpendicular to the corneal dome to get the proper full depth. So that's one caveat of technique. The second is, don't be afraid. Go in there, plunge the knife to the proper depth, and complete your incision before you change your depth and tape it out. I find people that have poor results or results that don't last often have the profile you see on the bottom of the screen where the incision was started and people then wimp out until they become almost subepithelial at the end of the case. You really want to be like the top diagram, even depth throughout the entire incision. This just shows you, there we go, we'll make it run, I hope. Not running. This is a video that was running in the ready room, not running here, unless you can do it. Just to show you one case of peripheral corneal relaxed incision, you can see this is the Dell marker. It may or may not run here, but this is the marker I tend to use. It's all-in-one. It's got an external bezel that controls points to the main axis of astigmatism, and an internal bezel that shows you the degree axis and that marks. It looks like we're not getting anywhere. Can we advance to the next slide if this doesn't run? Guys? And this one's not going to run. So let's go to the next slide, please. Complications over or under correction, including potentially a flipped axis, perforation. Make sure you know in the preoperative planning where you're going to place those incisions. Examine the peripheral cornea in those axes so you don't cut over a thinned area where there's a Dellin or corneal scar. If you've got a relaxed incision made within the corneal wound at 180, you can potentially get a wound leak. If you've got a PCRI that you make with the rule, it can possibly interfere with a paracentesis incision. You want to avoid that. So in summary, you need to know how to utilize both toric IOLs and peripheral corneal relaxing incisions. It should all be in your toolbox for managing astigmatism. And femtosecond incisions may allow a little more precise correction of astigmatism, especially when they're paired with toric IOLs.
Thank you for that excellent presentation. I have a question. You mentioned it there on your second last slide, is when the axis is on the axis of your incision, how do you handle that? Do you make it more anterior? Do you go through the LRI? Do you go?
So I go through the LRI, but I limit the size of my LRI to a maximum of 3 millimeters in length. And I make the incision, the LRI first. I take my phaco blade through it. So essentially, I'm creating a 3-plane incision that way. So I've created the depth. I go to about 50% of the depth of that LRI to advance forward and make my clear corneal incision. At the end of surgery, if you need more effect from that incision because your nomogram calls for it, you can then extend the incision with the diamond blade.
Jonathan, what's the maximum amount of astigmatism you'll treat with a LRI versus switching?
Yeah, it really depends on the age of the patient. In an older patient, if you've got somebody in their late 80s, you can get 2.75 to 3 diopters. A younger patient, you'll get a little bit less. So I'd say the max I've ever achieved is about 3 diopters, but that's sort of pushing the envelope.
Yeah, I think that the risk is with a larger LRI for people who don't do them, you can sometimes destabilize the cornea a bit and get some irregular astigmatism.
There's no question about it. So as far as degrees of arc, how far will I go? I'll keep it under 90 for sure, so 80 or less.
And there's an anesthetic effect. You're lopping off a lot more nerves when you make larger incisions.
Right.
What's your take on, let's say, LRIs versus arcuates with a femto? I mean, I think a femto, there's more control, but you're more central.
Right.
And do you think is one safer than the other? I mean, you've got the LRI, which is manual, surgeon controlled, so I could see it argued both ways.
Right. I think it depends on the surgeon. For those of us that have done the kind of existed and did manual LRIs before femto came around, and our corneal surgeons and are used to cutting in the cornea, I think that works extremely well. It's nice that it's peripheral.
Right.
People feel less foreign body sensation. The more peripheral the incision is, there's less induced irregular astigmatism from it. But if you're not really comfortable using manual incisions, you'll actually do better with a femtosecond laser. So I think it depends on the surgeon.
John, another indication for arcuate incisions is actually post-keratoplasty astigmatism. I know some people put toric lenses in these patients, but if you follow a PK patient or a DALC patient over time, the astigmatism changes.
Correct.
And I've seen toric patients actually over time do poorly,
Right.
Whereas I like arcuate incisions to manage the astigmatism and keratoplasty.
Yeah, I think that's a really good point. In general, if you're using toric IOLs, I think you should undershoot in the toric power and leave a little residual. You can always enhance that later with a relaxing incision. It's also, people have asked me, if you've got a post-keratoplasty patient, do you do a PCRI peripheral at the time of cataract surgery, or you do something preoperatively in the graft-host margin? And both of those are possible solutions.
Yeah, I just find if you're outside the graft wound, you don't get much effect. And actually,
Correct.
I'm concerned about doing it in the wound. I get overcorrection, so I do it just central to the wound. I think it's the most controlled for me. Any other comments? Great talk, John. Thank you very much.
you.
Our next speaker is